Well, one of the clear answers, of course, when you look at risk factor for breast cancer is having one of the BRCA genes, having a genetic
Correct.
predisposition. But I get a lot of questions from women saying it's a really expensive test. For a lot of women, it's not covered by insurance. Like, who should get it? How do you know when you should be BRCA tested?
So we're talking now about testing blood for a cancer predisposition gene that you've inherited from your mother or father. And so there are some hallmarks of the family history that might be a tip-off that there is a hereditary gene. And so that's, have people had cancer early in life, like prior to age 45? Have there been people that have had cancers in both breasts? That's a hallmark. Are there people who've had triple negative breast cancer? That might be a hallmark. Are there individuals in the family who have had colon cancer or thyroid cancer or ovarian cancer? These all can track with different predisposition genes. So the first thing you have to do is, get a family history. And if you are of a certain age or have people in your family that have had early cancers, then you might be a candidate for genetic testing. And now it's not just the BRCA genes,
Yeah.
but sometimes we find the gene that we find in a woman with breast cancer might be one that you think is colon cancer, a colon cancer gene, because these hereditary syndromes overlap. And now most people are doing panels of genes, not just looking at BRCA, but looking at the appropriate panel based on the type of cancers seen in the family. And then, what if you're adopted? You don't know your family history, and so that's an indication for testing. If you're a young woman and adopted and don't have any knowledge of family history, a reason for testing. So a lot of the cancer clinics now will have a genetic counselor available who can help the physician and the patient unwind the family history and make a recommendation about testing. And then insurance, if done appropriately, usually pays for it.
It's interesting because I just spoke with a woman. I think she tested BRCA negative, but then a sister, and they tested the mother. The mother was BRCA negative. So they're like, okay, everybody's going to be happy. Sister shouldn't have to worry about it. But then the sister gets breast cancer. And it turned out that it was the husband. It was the father that was carrying it. So I want to make sure that we make it completely understandable here. It's not just a woman who can carry the BRCA gene. It's also the father.
Right. And, in the olden days, we used to just say, did your mother have breast cancer? Not recognizing that these genes are carried by males as well as females. These are what are called dominant genes, autosomal dominant genes, and they can be passed from father to daughter, father to son, mother to daughter, mother to son. And so in the BRCA genes, it's relatively uncommon for men to have breast cancer, but yet they can pass the gene on to their daughters and their sons. And when you look at different families, sometimes it doesn't immediately look like the family history is that of a cancer family, especially if there's a lot of men in the family. If there are very few daughters in a couple generations, mostly boys, you can completely miss it. You maybe have like one other person who had lung cancer, and you have all these families of boys, and then boom, in the third generation, there's like a girl gets born and she gets breast cancer, and everyone's like, what? This has never been in our family. And in fact, that can be a BRCA family. So men, you know, they have a lot of defects, don't they, Joan? Men can have defects, and one of them is that they sadly can be the silent carriers of the BRCA genes through families.
And one other thing I just want to say is that I just spoke with a woman who got tested and was negative for BRCA1 and BRCA2, but they did a panel on her and found out that she has something called, I think, CHIK2.
Mm-hmm. CHIK2.
CHIK2, and so now we need to be cognizant of the fact that just because you're BRCA1 and BRCA2 negative does not mean that there's necessarily no other hereditary gene being spreaded. I don't know if they're called genes, that maybe they are, but we're finding that within the daughters of these women, it's getting passed, and everybody says, how can that be? She tested negative for BRCA. Right. So I guess we're learning more about other hereditary functions going on here.
Right. So in that example, the CHIK2, yes, we're seeing that a little bit more as we test these panels, but the struggle with CHIK2 is that we don't understand exactly what to do with it, what the real, should that woman be getting, preventive mastectomies or what. With BRCA1, BRCA2, and for any woman getting BRCA testing, you would want to do the third piece of that, which is the BART gene rearrangement. So it's 3 tests: BRCA1, BRCA2, and the BART gene rearrangement. So we know a lot about that, and we know what the risks are of second cancers, and some good information to guide women about the probability of getting a second cancer. Maybe not so much with CHEK. Another gene that tracks through these families where we're evolving very good information is P10. It's all big letters, capital P-T-E-N, and that's a gene that tracks through families that have what's called Cowden Syndrome. And Cowden Syndrome is important because it incorporates breast cancer and thyroid cancer. So women who carry a P10 gene, as part of their survivorship, we monitor their thyroid. So, we're getting smarter and smarter and understanding how to use these genes, but on those panels, there's some genes that we just don't know what the right surveillance recommendations are yet.
All right. We always learn so much when we speak with you, Doctor.
There you go.
Thank you very, very much. Until next time.
Okay.